Hello everybody, I'm back. Dr. K.K. Agarwal, President, Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania, and you are watching Med Talks with Dr. K.K. Agarwal, 148 non-stop 7 p.m. show. Let's have the headlines of the day. The daily new COVID-19 cases fell below 30,000 for the third time this month, taking Indian virus caseload to 98.84 lakh. The Minister of Health, Ashwani Kumar Chaubey, said 100 people would receive the COVID vaccine at booth per day. Eventually, everyone will get. The Kerala tops the list by percentage of the population needing vaccination. The government is preparing to vaccinate about 19.5% of the population, making up the 50-plus age group. Singapore approves Pfizer COVID-19 vaccine, expects first shot by the year end. German biotech firm CureVac has enrolled the first participant for phase 2b/3 clinical trial of the COVID-19 vaccine candidate. Before I go to the subject of the day, let's do our ritual. And our ritual is to teach people how to wash hands. That's something we have to learn forever, because that's not going to take care of only COVID-19, but also all food and waterborne diseases. So we take a gel and then we say Seedha, Ulta, Mutti, Angutha, Nakhun, and Kalai. By the time the gel is evaporated, and you are free to invite your guest, and my guest is going to be none other than Dr. Jagdish Chandra Suri. He is an eminent pulmonologist, critical care and sleep medicine expert with over 35 years of experience in this field. He is the Director, Pulmonology, Critical Care and Sleep Medicine at Fortis Hospital, Vasant Kuch. He was a former consultant professor and head of Pulmonary, Critical Care and Sleep Medicine at Vardhaman Mahavir Medical College, Safdarjung Hospital. And he was the originator of sleep medicine in India. He has many contributions toward Government of India national programs, national TB programs, and he has been a national advisor for the pulmonary group at the DCGI level, and in proposing very drug trials submitted by various pharmaceutical companies. And let me now introduce the subject. Ritu, let's have the subject. So pulmonary fibrosis in COVID-19 is the topic of the day. Only two topics are in the market: pulmonary fibrosis and vaccine. We have been covering vaccine a lot. So let's now cover pulmonary fibrosis. होगी, नहीं होगी, होगी तो कितनी होगी, कैसे बचाएं, कैसे treat करें, कैसे find करें. Everybody today is afraid that I had a mild pneumonia. Am I going to enter into a pulmonary fibrosis? I request Dr. Suri for the first part of this program, he will speak out on pulmonary fibrosis, and then we will have discussion, and if the time permits, we'll allow one or two questions from the viewers. Dr. Suri.
Thank you, Dr. K.K. Agarwal, for inviting me for this very important talk show. And the topic, as you mentioned to me, is very, very important topic. It is a hot topic and being discussed at various forums. The information is limited, but whatever information is there, I'll try to discuss with you, and later on try to make some message or information out of it. How to share this thing? I'm not able to.
You have to go down to share screen.
Yeah.
Just put down share screen, then you go to application window.
Okay, application window is not coming,
No, you'll have
Uh,
to. When you go
let's see.
down, put down share screen, then it will give you three options: your entire screen, application window, and Chrome tab.
That is not coming. That your
On the top, above the slide, above, share your screen. Then StreamYard.com wants to share the content of your screen. Then you will get your entire screen, application window, and Chrome tab.
some other win. Just a minute.
Put on the application window.
So first of all, stop your screen sharing. Then
Let
start
me
again.
stop share. Now share. I will share screen first.
First share
Yes.
screen,
Yes, I have
then
shared. Then what next?
application
Because
window.
I'm getting a window where application window. Okay.
Correct.
Now
You choose
Select
your
it.
slide.
Yeah, it's come.
have they started coming?
Yes.
Okay. So what I'm going to do in my talk is to discuss about what the fibrosis is, risk factors, and prevalence of post-COVID uh, fibrosis in the patients which we are seeing. How fast this fibrosis develops in these patients. What are the proposed pathogenetic mechanism and possible management approaches? As you all know, pulmonary fibrosis is a permanent pulmonary architectural distortion and irreversible lung dysfunction. We have seen this problem also in previous coronavirus infections like SARS-CoV-1 and Middle East respiratory syndrome disease, MERS-CoV, which we saw around the year 2012 in Saudi Arabia. And we have also seen this kind of fibrosis in patients with H1N1 flu. Uh, the proof of having fibrosis in patient with SARS-CoV-2 is when we did the autopsy studies, and many of these patients who died of COVID-19 had fibrosing or organizing pneumonia and diffuse alveolar damage and fibrosis in these. The predictors for developing pulmonary fibrosis in COVID-19 patients are advanced age, severe illness, those who have been in the ICU receiving mechanical ventilation, and also patients who have a history of smoking and alcohol intake. So, if you we have very preliminary data at the moment. There are a lot of studies going on, but as the time goes on and more information comes, the exact prevalence of COVID-19 will become more and more apparent and more clear. But the early analysis of the patient which we have so far indicate that those patients, particularly those who have been admitted in the hospital, in the intensive care or in the high dependency unit, more than one third of these patients developed fibrotic abnormalities. Additionally, about 47% of the patient had impaired diffusing capacity of the lungs and also decrease in their total lung capacity. So this particular thing seems to be worse in patients who have severe disease. How fast the disease evolved. Now, this is a very important systematic review and a guidance document which was published in BMJ Thorax in July. And in this systematic review, what they have done is they have followed up these patients with lung functions, with CT scans, and these were basically high risk patients. Who are the high risk patients? Those who were in the intensive care unit or in the HDU, those who received oxygen when they were discharged from the hospital, or those who have remained in the ICU for a long period requiring high FiO2, high fraction of inspired oxygen. They were on, say, rebreathing masks, and those who required NIV or invasive mechanical ventilation. And you can see here from the CT scans of these patients, in the early phase of their illness, you can see there are gross changes of ARDS. You can see bilateral pneumonias, consolidations, and also patches of organizing pneumonia in these patients. And then what was found that once they recovered, and discharged from the hospital. And when they were followed up for some period, what we found that uh, the radiological changes do not appear to resolve fully in all these patients. And in some, inflammation matures to form what you call the residual pulmonary fibrosis. So you can see here, this is a patient who has recovered from COVID-19, who had severe ARDS, who was in the ICU, receiving NIV, and you can see that there is evidence of linear shadows and fibrosis. Now, the next question comes, how fast the fibrosis can develop in these patients? Now, this was one series. You can see at day zero, their CTs were normal when they were admitted in the very, very early stage. And then by 3 weeks, they have extensive inflammatory changes with organizing pneumonia. And by 6 weeks, you can see these pneumonias have changed into significant fibrotic changes. The another study where you can see that even this, you can see here, this is a mild ground glass appearance. And 3 weeks later, at the same zone here, you can see that there is development of progressive fibrosis. So this is something very interesting, that even at 3 weeks time, there can be development. And this is another study which shows, in fact, from day 0 to day 7, there is a significant development of fibrotic changes. On the left side, you can see the ground glass opacities indicating organizing pneumonia-like picture, airspace lesions, consolidations, and they have changed into those linear reticular shadows to fibrotic appearance, with in some cases some traction bronchiectasis. So what it means, that even at 7 days of illness, you are seeing fibrotic changes. So this means this is primarily an inflammation, which has combination of both consolidation and also activation of fibrosis. So it's from day one. The mechanism is such that there is a de novo process of fibrotic changes. So what we are seeing here is in the pathogenesis of fibrosis, that there is when the SARS-CoV-2 virus enters into the lung, it combines with the ACE2 receptors, and then it results in acute or chronic inflammation. So this inflammation basically results into alveolar epithelial damage. With the result, there is an overexpression of pro-inflammatory cytokines like TGF-beta, TNF-alpha, and IL-6. And then, there is not only the activation of inflammatory pathways, but there is also activation of fibroblasts and myoblasts, leading to laying down of excessive collagen in the extracellular matrix. So it appears that there is a simultaneous inflammation, exudation, and accumulation of inflammatory cells, and also activation of fibroblast and myofibroblast and fibrosis. So that's why you are getting a kind of a mixed picture. And what we have seen recently, that this SARS-CoV-2 virus induces some kind of transcriptional signatures in the human lung epithelial cells, which result into activation of these fibroblast and myofibroblast that promote lung fibrosis. So you can see here, in the alveoli, these virus enters, combines with the ACE2 receptors, and then there can be a direct death, apoptosis, or dysfunction of these cells, leading to inflammation, damage to the surfactant. And so ultimately, there is a diffuse alveolar damage, acute respiratory distress syndrome picture, as you can see here. So this is what you are trying to see. So what happens, in the recovery? So most of the patients who have a mild disease, who do not develop ARDS or pneumonias, they recover without any residual sequelae in the lung. But those who develop pneumonias or ARDS, the adequate recovery requires reepithelialization. this reepithelialization is usually done by the alveolar type 2 cells, which proliferate and differentiate into alveolar type 1 cells. There is also removal of hyaline membrane material, regression of stromal cells, and leukocyte accumulation. But in those cases where the injury is very extensive, where there is a significant depletion of alveolar type 2 cells, so this recovery or reepithelialization does not occur, and that results into basically stimulation of fibroblast and myofibroblast, leading to development of lung fibrosis. So what are the possible management approaches we can have at present? You know that at present the treatment can be anything, right from traditional Chinese medicine to antiviral drugs to corticosteroid to immunosuppressive drugs to even antifibrotic drugs. So all these kinds of drugs are being tried, and how good they are, we have yet to see from a high level scientific data. We know that corticosteroids, you are all aware, from the recovery trial, which shows that dexamethasone, when given in acute phase means when a patient comes with acute pneumonias and when they develop moderate to severe disease and when they require oxygen, these are the patients, if given corticosteroid, it results into significant improvement in the mortality. So with the same logic, it appears that if you continue these patients with steroids, because it is the same inflammation, this can lead to probably prevention of development of fibrosis in this thing. And anecdotally, it is being used, and some patients have recovered. So what people are doing is, because in the recovery trial, the recommendation for giving corticosteroid was for 10 days only. So those patients who do not recover completely in this period, those who continue to have inflammation, still the X-rays or CT scan shows ground glass opacification and foci of organizing pneumonia. Those who continue to have respiratory symptoms and lung function impairment, these were the patients who were given a continuation of steroid for another 4 weeks to see for improvement. Now, many people are trying these antifibrotic drugs. Now, the question is there a rationale to give antifibrotic drugs to these patients? We know pulmonary fibrosis is probably the consequence of immune dysregulation, which is caused by cytokine storm. And I also mentioned to you that there is a simultaneous activation of both inflammatory and fibrotic pathways in this thing. And the type of chronic inflammation which we are seeing in patients with COVID-19 and the type of pro-inflammatory cytokines like TGF-alpha and IL-1 beta, these are the the kind of mechanism we actually see in patients with idiopathic pulmonary fibrosis. So there appears to be some similarity in the type of pathogenesis in the development of fibrosis in patient with the COVID-19 and also patient with idiopathic pulmonary fibrosis. So that is what is leading to the recommendation of giving these kinds of drugs. But the question is post-COVID-19 fibrosis, is it or this inflammation reversible, or this fibrosis reversible or progressive? What you see in patients with idiopathic pulmonary fibrosis, because at present the antifibrotic drugs are mainly given to patients who have a progressive fibrosis, as we see in patients with the IPF. But do we really have an evidence to show that COVID-19 fibrosis is progressive? At present, there is no definite criteria. There is very scant data to show that. And then all those patients who develop active inflammation will not ultimately develop fibrosis. So we do not know in the early phase which patient is going to recover completely and which patients are going to develop fibrosis, because at present we do not have any biomarkers to tell us that these are the patients who are likely to go to develop fibrosis, and then we should start antifibrotic. And if we have to start antifibrotic, probably you will have to start them very early in the course of illness before actually the fibrosis develops. So we do not have any such kind of guideline, any such kind of data to do that. But what we know that instead of these biomarkers, what we know that patients who have got a very severe disease, who require mechanical ventilation, those who require early corticosteroid and oxygen, and those who require use of immunosuppressants in the acute phase like tocilizumab and other thing, or if the radiological pattern is similar to what we see in IPF, that UIP like pattern, maybe those are the patients who may develop fibrosis for this thing. But now the question is, before we get that kind of information, that this fibrosis is progressive and will cause further damage to the lung and we should give these drugs, let us see some experience from previous SARS infection. Those were also coronavirus infection. I mentioned to you SARS-CoV-1, which we saw in 2002 to 2003-4, and also MERS, which was seen in 2012. What is our experience with that? And what we have is basically a 15 years follow-up of medical staff which was infected with SARS-CoV-1 virus in 2003. And what we have found that when those patients who had developed this infection who have lung lesions, the percentage of lung area with pulmonary lesion diminished from 9.4% to 3.2% in the first 2 years. And subsequently, after 2 years, that means from 2003 to 2005, there was an improvement in their lung lesion, there was an improvement in their fibrosis, and after that, for 15 years, their lung functions, radiological pictures has remained stable. In other words, the fibrosis which were developed by previous SARS infection or MERS was not progressive. So subsequently, what we can say that the lung fibrosis after ARDS, how does it differ from ILD or particularly IPF, which is a progressive fibrosis? The infection caused by H1N1 influenza, 2009. Again, we found that this was non-progressive and may actually partially improve during early follow-up. In fact, we are also seeing our SARS-CoV patient in the last 2-3 months. None of our patients have progressed or deteriorated, actually, this thing. So there's another study, follow-up study of pulmonary function and lung radiographic changes in rehabilitating severe acute respiratory distress syndrome. Again, what we have found that it is a non-progressive fibrosis and actually may improve partially on early follow-up. So you can see here, 40 of the 51 patients shows lung fibrotic changes and in the early examination, and 22, that means 55% showed improvement in the lung fibrosis. So these are the findings, which shows that the role of antifibrotic drugs may be limited in this thing. And if at all, you may have, if you are using, because this fibrosis becomes stable very fast. And before it becomes stable, if you want to prevent it, probably you may have to use these kinds of drugs, So the question then comes, is there a role of antifibrotic therapies in COVID-19? There are some issues, for antifibrotic drugs to potentially work in COVID-19. First of all, they should have a very rapid onset of action, because if you are giving them very early before the fibrosis develops and in the acute inflammatory state, and they should act very fast, which we know that they are very slowly acting drugs, and they have to be instituted early before mechanical ventilation. And for that, you need early biomarkers. Otherwise, you may be probably over-treating large number of patients. And you also need to have a non-oral route for critically ill patients, because these are the tablets which are there. You may not be able to give to many of these patients. So nebulized pirfenidone is now in trials, and it also needs to be combined with anti-inflammatory drugs. So you may have to use a combination of maybe steroids and this thing. Currently, there is no basis for empirical off-license treatment. So antifibrotic needs to be evaluated in these following conditions. First, can antifibrotic prevent severe COVID-19 acute exacerbation in the existing ILD patients? Number two, can antifibrotics prevent fibrosis in COVID-19 patient without ILD? And the last is, can antifibrotics mitigate or treat fibrosis in severe COVID-19 patient without ILD? So these are the things which we have. These are the current trials, as you can see, nintedanib and pirfenidone. These trials are being done, and to see, we'll have to wait for their results. So to summarize, post-COVID-19 complications and fibrosis are very common, and involved about two-thirds of all patients with increasing prevalence, with increasing severity of the disease. They range from varying degree of pulmonary fibrosis to involvement of also cardiac, neuropsychiatric, renal, and coagulation system. It appears that pulmonary fibrosis develops early in the course of illness, and whether it is progressive in nature is not yet fully clear. At least the present studies do not give that kind of indication. Antifibrotic therapies with broad antifibrotic activity, regardless of etiology, might have a role in attenuating pro-fibrotic pathways in SARS-CoV-2 infection. So these drugs may have a role early in the course of illness in preventing the development of fibrosis. However, we lack the biomarkers at present to predict the patient at high risk of developing fibrosis. So to sum up, the long COVID or the long haulers are real, they are common, and we are going to see more of them in future. There is an urgent need of much more research in this area for better management of these patients. These patients need to be evaluated regularly with pulmonary function tests, echoes, CT scans, or X-rays for understanding the long-term outcome of these patients. The role of chronic inflammation, fibrosis, and intravascular thrombi also need to be defined in the causation of various symptoms. COVID-19 is a unique and novel infection that has already demonstrated a range of perplexing clinical syndrome. Its legacy will be felt long after the pandemic has passed. It is vital that the respiratory community is primed to detect and manage the long-term consequences of this infection. Thank you for your kind attention, and I'll be very happy to take some questions.
Thank you, Dr. Suri, for an elaborative talk on this particular thing. Can I close the slides?
Yes, I'm trying to look for that.
Yes. So as this program is live on MedTalks, which is our doctors platform, and it is also live on YouTube and Facebook, where people also join, general public. So next 10-15 minutes, I will talk to you in a bilingual language, Hindi and English mix. सबसे पहले ये है कि there is in this condition we get precipitation of pyroptosis, which is inflammatory apoptosis, which leads to activation of macrophages and which ultimately leads to formation of fibrosis. तो इसमें आपने दिखाया था IL-1 beta. So IL-1 beta is involved in a natural process of interstitial lung fibrosis. IL-1 beta has a different pathway than a TH1 pathway. TH1 pathway is for IL-6, TNF, and IL-8. Yes. And NLRP pathway and this nuclear factor Kb pathway leads to IL-18 and IL-1 beta. So ऐसा देखा गया है कि IL-1 beta pathway is responsible for this ferritin increase and hyaline membrane formation. So अगर हम IL-1 beta inhibitors दें along with steroid, तो शायद I'm hypothesizing that अगर मैं IL-1 beta को IL-1 beta मेरा है कि if the fever is more than 101, because IL-1 beta is it is called as a pyrogen. It is a pyrogen interleukin. So इस situation में क्या colchicine and mefenamic acid दोनों specifically IL-1 beta पे काम करते हैं. और अब हम कार्डियोलॉजी में हम लोगों ने नई स्टडीज आ गई हैं that every patient of cardiology with a HSCRP between 1 and 3 should be put on long-term colchicine to control IL-1 beta. और यहाँ पर भी जब फाइब्रोसिस खत्म हो जाती है उनका CRP 1 से कम नहीं आता और 1 और 3 के बीच में रहते हैं, यानी कि लो ग्रेड इन्फ्लेमेशन रहता है. Do you feel that in such cases, that's what I hypothesize and I treat my patients, add on to that, because I believe in a pandemic जो harm ना करे शायद फायदा कर दे, तो देके देखो. So do you feel that colchicine and mefenamic acid may have a role along with steroids in preventing formation of hyaline membrane, angioneogenesis, and that's one. And the second is that 3 things which are described in Vedic medicine is, we call them as salt, which is sukha adrak, which is Kali Mirach and which is Pipli, they are supposed to be increasing phagocytosis. There are n number of studies in our Medline where the modern medicine doctors have done studies on Tricotu as a product for increasing phagocytosis. I know we are not supposed to speak, but then I'm funding from the Medline studies where they say these three natural herbs increases phagocytosis, reduces pyroptosis, may reduce fibrosis. Just wanted your, these are my hypotheses, not, there's no evidence, these are just hypotheses from the literature. Dr. Suri.
Yeah, I think I think you have given a very good account of various pathways, and the inflammation and the immunological pathways which are associated with the SARS-CoV-2 are very complex. As we know that there are two pathways. One pathway leads to inflammation and immunity and recovery, rapid recovery, as we see in large majority of patients. The second pathway, where probably the viral load increases too much, it goes to the second, where you have dysregulated immune response, IL-6 and other thing, and also activation of fibrotic pathways. So the thing is that it is very difficult to actually select these patients clinically, because we don't have very clear-cut biomarkers. What we have basically C-reactive proteins, you use ferritin, you use D-dimers, in some cases LDH. Now, there is no direct correlation between these inflammatory markers and the severity of illness, and there is no very clear-cut improvement at the rate at which they improve with the resolution of disease. So there are only empirical cutoff lines, cutoff points which we make, and the treatment basically which we are doing is based on very few of these inflammatory markers, and till we have some better biomarkers, our treatment approach will remain empirical, and where you will keep trying different things, and because the time is at the moment when the epidemic is in its full swing, and the results of the randomized control trials are going to come after a long time. So the various things which you have mentioned, I think there is no harm in trying, as long as if you have looked into the risk-benefit analysis, the side effect.
I will give you one more experience of mine, because I basically do a electronic practice and an OPD practice, and I've gone through a lot of literature of Vedic sciences and modern medicine sciences. So I say when the virus enters my body, it will produce interferon 1A, which will lead to gamma interferon, PLA2 steroids, PLA2, and then it causes inflammation, which is the low-grade fever. हमारे को इस कंडीशन में दो टाइप के फीवर मिल रहे हैं. एक वो फीवर है जो 100 से कम है, और एक वो फीवर है जो 101 से ज्यादा है. जो 100 से कम है उसे हम बोल रहे हैं thermoregulatory dysregulation, and we are saying IL-6 fever, because IL-6 crosses blood-brain barrier and changes the biological clock at the level of hypothalamus. जैसे ही फीवर 101 क्रॉस करता है, I have done around 1000 patients only on this criteria. If the fever is more than 101, and we have checked the CT scan, it shows pneumonia. So हमारा एक marker है fever of more than 101. It means there is a patch. Or we say is if the CRP is more than 10. पहले हम 26 का लेके चल रहे थे, पहले हम 40 पे आए, फिर 26 पे आए, हम कट ऑफ करते करते 10 पे आ गए. अब हम देख रहे हैं जिसका CRP 10 से ज्यादा है उसको हमें निमोनिया का पैच मिल रहा है. और जैसे ही फीवर मोर देन 101 आता है, so I am taking it as a IL-1 beta fever. I am not calling it as a IL-6 fever. पर अगर ये IL-1 beta fever है, तो because why we are talking about it? Because my patients were saying, they were vouching कि डॉक्टर साहब पैरासीटामोल से फीवर नहीं जा रहा. This is mefenamic acid, naproxen या इंडोमिथन से ही फीवर जा रहा है. It reminded me of Dr. Malviya, who used to teach us immunoinflammation will respond to only naproxen or mefenamic acid. So I started working on immunoinflammation with Genesis. Then I found the most interleukin pyrogen is IL-1 beta. And IL-1 beta में मैंने मेफेनेमिक एसिड को निकाला, एंड मेफेनेमिक एसिड से इट इज कॉजिंग, पेशेंट कहता है मेफेनेमिक एसिड लेते ही डॉक्टर साहब मेरे को तो कॉन्स्टिट्यूशनल सिम्टम्स सारे खत्म हो गए. देन आई स्टार्टेड रीडिंग मेफेनेमिक एसिड काम कहाँ करता है. Then I found out that different types of pathways involved: NLRP, nuclear factor kappa beta pathway, arachidonic acid pathway, TH1 pathways. So ये चार pathways इस बीमारी में involved है. So then I started looking, why not treat each pathway and try to reduce the dose of. अब जैसे ये बेरिसिटिनिब आई है, ये न्यूक्लियर लेवल पे, ट्रांसक्रिप्शन लेवल पे, जैक स्टैट पाथवे पे काम कर रही है. So this may be even better than tocilizumab and better than, जैसे फॉर एग्जांपल मेरे को स्टीरॉयड को अपग्रेड करना है. सपोज आई एम गिविंग ए लो डेज, एवरी ट्रायल पर 40 मिलीग्राम दे रहा हूँ, और अगर मैं उसको 1 मिलीग्राम पर केजी पे ले जाना चाहता हूँ तो कितने दिन के लिए दूँ. उसमें अगर मैं बेरिसिटिनिब डाल दूँ तो 3 दिन के बाद में स्टीरॉयड स्पेयरिंग हो जाएगा. तो ये मेरी थिंकिंग, आप लोग तो एक्सपर्ट्स हैं, आई एम ओनली ट्राइंग टू फाइंड आउट इट आर माय assumptions correct.
I think काफी interesting है.
High court lawyer is arguing in a Supreme Court.
It's very interesting what you are saying. But what I can tell you that once you give patient steroids, see, any patient who comes with mild disease, whose oxygen saturation is more than 95, and whose fever is low grade and is coming down, I think we need not bother, we need not do anything, because when oxygen saturation is 97, 98%, that means the lung involvement is very low and we should not be bothering much. But once the patient starts requiring oxygen, that means his oxygen saturation has gone below 90%. That means the inflammation is quite significant. So there definitely, there is only one high quality scientific evidence is steroids. So in that trial, the dose of steroid 6 milligram for 10 days. That's all what they have studied. But we know that there are many patients who actually go into chronic inflammatory state, and they do improve on steroid, but they do not completely recover. So I think these are the patients where you may have to continue steroids on a longer period of time, maybe in a gradually tapering doses. And in such cases, what you are saying is that you want to use these drugs as a steroid sparing drugs, and you don't want to give them the side effects. And this thing, the idea is very clear that why we want to give steroids to these patients is to prevent fibrosis, to prevent lung sequelae, and also to treat extra pulmonary, manifestation in the brain, in the heart, and other nervous system complication which we are seeing. So I think what personally I feel, steroid probably may be the best bet under such circumstances to prevent these sequelae. But how long we have to give, that actually varies from patient to patient. So we keep monitoring them with maybe inflammatory markers, and many times inflammatory markers become normal. You taper off the steroids, stop them, and within few days again the fever will go up, the markers will go up. So we don't know for how long we have to continue. And in such cases, role of these mefenamic acid and other drugs, I think, becomes very important. But it needs to be studied a little more, I think, scientifically.
I've been watching on day 1, day 2, day 3, day 4, day 5, day 6, like that. So in day 1, I say low-grade fever, and other local symptoms I am not bothered about it. And normally when you read about CRP should start rising within 4 hours of an insult, should double every 8 hours, should peak before 48 hours, and when it crashes within 17 hours. So हम लोग CRP daily कराते हैं because that's cheap, easily available, and we are following that. Number one is we find out whether the virus is active or not by taking a CRP vis-a-vis NLR ratio or lymphocytic count. If the absolute lymphocytic count is reducing and CRP is increasing, so we say virus is replicative. This is an indirect marker. So if I find that TLC lymphocytic count is going and CRP is rising, so I say local as well as systemic response is occurring, so the virus is active. On 7th day, lymphocytic, because we say on 7th day the virus is dead. So on the 7th day, the CRP should stabilize. CRP may not stabilize because that's a marker of inflammation, but NLR ratio should stabilize. NLR ratio should stabilize. So if on seventh day we find NLR ratio is not stabilizing, that's a sign of upgrade the steroid dose if you are giving. And for my criteria for giving steroid is that if I find fever more than 101, with he has a reducing lymphocyte with presence of opacities in the lung and CRP more than 10. So I say this is an acute inflammation. Before he goes into hypoxia, let me stop it here. That's the marker I use. If I wait for the hypoxia, it may be a little bit too late. So I would take 3 as a criteria. If the CRP is more than 10, and if I find NLR ratio is reducing, fever is more than 101, and CT scan is showing generalized obesities, usually the count will be 5 to 7 per 25. I'm talking about 25% involvement of the lung. And in such cases, when I repeat after 48 hours, so I'll start with a low dose of steroid, reevaluate them after 48 hours, taking into criteria that those cases which you are talking about will end up into fibrosis, should worsen within 48 hours. And if I find within 48 hours of starting steroid, colchicine and mefenamic acid, if their CT scan shows worsening by another 50%, that means my doses are low. I need to upgrade the steroid dose to 1 milligram per kg instead of 40 milligram prednisolone. I mean, in OPD practice, this is how I follow and try to examine these cases. So what I have found out is very few patients ends up with the oxygenation. They don't require oxygenation, they get controlled. And then if I find after 8 days, if I say if I am tapering steroid, within 24 hours, the CRP will go up. So I do a sequential CRP along with when I'm withdrawing CRP. So I'm taking CRP as a marker, thinking CRP is indirectly telling me about IL-6 and CRP indirectly telling me about fibrinogen, because IL-6 will direct the liver to make both fibrinogen and CRP. So therefore, because IL-6 requires within 1 hour, the serum has to be withdrawn. No lab is doing correctly IL-6 and D dimer. 7 बजे सैंपल लेते हैं, 9 बजे लैब पहुंचता है, वो तीसरी लैब में पहुंचता है, तब तक 1 घंटा निकल जाता है. एंड वी नो दैट जब वो सैंपल शरीर के बाहर है और आपने सीरम सेपरेट नहीं किया, तो वो lymphocytes को they will go on increasing IL-6 producing. So IL-6 and D dimer may be higher if the test is not done within 1 hour. तो इसलिए मैं अल्टीमेटली मैंने CRP पे आ गया, एंड मेरे को CRP से बहुत अच्छे रिजल्ट्स मिल रहे हैं.
My only thing is that if in the very early stage of the disease, means first few days, if steroids are used, they can actually enhance viral replication. And after 7 days, when you think that the virus is dead, because why we think virus is dead in 7 days? Because the immune response has set in by that time. So it is the viral load at the end of 1 week which decides the subsequent course. If the viral load has come down significantly at 7 days, the course will always be positive. It will be more in favor of the patient. But if suppose we have due to some reason suppress the immunity, and our innate immunity is not very good with the use of steroid, then the viral load, instead of becoming less at the end of 1 week, actually become too high. And because of the relative antigen excess, actually the alternative immune pathways are activated, leading to severe ARDS. So the picture which we are seeing, first picture is that of viral pneumonia. And the next 7 days after that, what you see is the ARDS-like picture, which is a part of dysregulated immune response. So that is the time, steroids actually should be given. And why we have a small number of patients who develop this kind of serious diseases, because in majority of patients, the innate immunity is good and it takes care of the virus in the early phase and the viral replication is stopped. It is only in those patients where the innate immunity is not working and the virus, multiplies unchecked and by 7 days the viral load becomes too high, and that leads to dysregulated. So I think maybe one way you can see is that at the end of
I agree, agree. पहले हम यही कर रहे थे, सो बाद में हमने, क्योंकि हमने मेफेनिमिक एसिड और साथ में कॉल्चिसिन को डे 1 से स्टेरॉइड के साथ में ऐड करना चालू किया, तो हमने ये देखा कि इन्फ्लेमेशन इतना बढ़ता ही नहीं. दैट इज, आई एम ओनली टॉकिंग अबाउट एनेक्डोटल ऑब्जर्वेशंस. आई एम वेल अवेयर कि हम तो पहले देते ही नहीं थे, स्टेरॉइड देते हुए डरते थे, बट हमने क्राइटेरिया बना लिया है कि अगर IL-6, अगर CRP मोर देन 10, so we have to demonstrate active inflammation, then only we start steroid.
Achha, one thing which I want to ask that though these drugs are good anti-inflammatory, but do they have any effect on the virus? But how is the virus going to be controlled?
तो वायरस के ऊपर कई सारे रोल आते हैं. एक तो हम लोग साथ में आइवरमेक्टिन एंड डॉक्सीसाइक्लिन देते हैं, व्हाटएवर क्वेरी रोल इट हैज. ठीक है. Third thing is melatonin. We have started using a lot of melatonin because it is now confirmed that melatonin acts at various levels. Okay, melatonin now is working as an anti-inflammatory and antiviral effect. So जो भी हम कर सकते हैं antiviral effect के लिए साथ में देते हैं. So zinc appears at the level of TMP RSS के टाइम पे जिंक आता है, वहाँ काम करता है. ब्रोमेक्सिन हमारे पास में सीरीन इनहिबिटर के लेवल पे काम करता है. मेफेनिमिक एसिड वर्क्स एट द लेवल ऑफ सीरीन प्रोटीएस इनहिबिटर, जो ACE2 के साथ में जो क्लीव करेगा प्रोटीन, सीरीन प्रोटीएस जो है, वहां पे मेफेनिमिक एसिड भी नोन है. ये सब क्वेरीज हैं. सो वी पिक अप 4 or 5 थिंग्स व्हिच में एक्ट विद अ पोटेंशियल कि शायद कम कर दे. सी, हमने एक चीज को, आई डिड ए लॉन्ग सेमिनार ऑन एथिक्स विद यूनेस्को ऑन दिस पर्टिकुलर बेसिस, और उसका निष्कर्ष ये निकला था कि पेंडेमिक में जो नुकसान ना करे, शायद बेनिफिट कर दे, तो दे देना चाहिए.
इनफैक्ट सारी रीपर्पस जो ड्रग्स हम यूज कर रहे हैं अभी, वो इसी बेसिस पे ही तो कर रहे हैं.
तो मैं तो सिर्फ पढ़ाई करके मेरे को लगता है यहाँ पे अटैक कर सकते हैं, नुकसान नहीं करेगा, क्योंकि एज इट इज नॉट ए प्रोग्रेसिव डिसीज. ये तो वन टाइम इवेंट है. देना है 3 दिन, 5 दिन, 7 दिन के लिए. एवरमेक्टिन 3 दिन देना है, डॉक्सीसाइक्लिन 3 दिन देना है, मेफेनिमिक एसिड 5 दिन दे भी दिया तो क्या है, एज लॉन्ग एज पेशेंट इज नॉट ए CKD पेशेंट. So we are trying to read out. This is the first time we have gone into molecular level reading. इस वायरस ने हमारे को फोर्स कर दिया है molecular level पे पढ़ो. अब जैसे नेचुरल स्टेरॉइड प्लांट्स में कालमेग है. इफ यू रीड कालमेग, मैंने इसको लोगों को पढ़ाता हूँ. का फॉर के कहते हैं, का फॉर कोरोना, का फॉर कोविड, का फॉर कड़वा, का फॉर कसेला, का फॉर करेला, का फॉर कालमेग, का फॉर ये जो होती है काफर कालमेग, एंड एक और था ना ये कलौंजी, काफर कलौंजी. ये सारे मैंने पढ़े हैं. ये सारे एंटी इंफ्लेमेटरी पाथवेज पे काम कर रहे हैं. अगर आप डीप जाओ इनके अंदर में, कोई न्यूक्लियर फैक्टर कपा बीटा पे काम कर रहा है, कोई IL-1 बीटा पे काम कर रहा है, तो व्हाई नॉट टेक द बेस्ट ऑफ एवरीथिंग. अब ये किसी को मैं बोलता हूँ कि तू करेला खा ले, वो नुकसान थोड़ी करेगा. तो हम बोलते हैं कलौंजी अचार में डालते हो आप लोग, तो मैं बोलता हूँ कि अचार खाओ, करेला खाओ, अचार खाओ. तब जब हमें डाइट बोलनी ही है तो हम इस डाइट को साथ में ऐड कर देते हैं, बिकॉज किताबों में लिखा है, स्टडीज के अंदर में, कि वो न्यूक्लियर फैक्टर कपा बीटा पे काम करता है. कलौंजी पे कह रहे हैं कि वो ब्रोमेक्सिन वाला काम कर रहा है, कालमेग. सो हम इसको ऐड कर देते हैं. अब क्या काम कर रहा है हमें भी नहीं पता, बिकॉज हमारे काम तो इस वक्त में यही है, पेशेंट की जान को बचाना. एविडेंसेस क्रिएट करना आप लोगों का काम है. हम तो सब जगह पे एनेक्डोटल हमारे एक्सपेरिमेंट्स आगे लोगों को देने की कोशिश कर रहे हैं. अब जैसे पोस्ट कोविड में हम लोग कॉल्चिसिन, अगर पेशेंट का CRP 3 से ज्यादा है, एसिम्प्टोमेटिक है, वी टेक इट फॉर ग्रांटेड. अगर हमने उसका CRP 1 से कम नहीं लाए, so they will end up into within 2 months into a multi-system inflammatory disease. I am seeing a lot of multi-system inflammatory disease in adults. 1 महीने के बाद में किसी को डेंटल एब्सिस हो रही है, किसी को कुछ हो रहा है, suddenly lymphocyte drops, they have acute Th1 response and they respond to high dose steroid. The antibodies are positive, RT-PCR is negative. सबको मैं प्रीवियस जाके देखता हूँ, ये सारे वो लोग हैं जिनका इन्फ्लेमेशन बंद नहीं हुआ था. मैं लोगों को बोलता हूँ कि आपकी भट्टी अगर गर्म है ये वायरस आता है, तीली छोड़ के आग लगा के निकल जाता है, साइटोकाइन फायर बोलते हैं इसको। और अगर आपने साइटोकाइन फायर को पूरा सप्रेस नहीं किया तो कोई दूसरा ट्रिगर आके उसमें आग लगा देगा। तो ये जो मल्टी सिस्टम इन्फ्लेमेटरी डिसीज है, आई एम सीइंग ऑलमोस्ट एवरी डे वन पेशेंट मेरे को, क्योंकि आई एम गेटिंग कॉल्स फ्रॉम ऑल ओवर द कंट्री। सो उनको सबका पैटर्न यही है, दूसरा महीना एंटीबॉडी पॉजिटिव, आरटीपीसीआर नेगेटिव, lymphocytic count less than 10%, CRP 100, pneumonia, no pneumonia. All these patients are, there is a sparing of pneumonia. So what we are saying is, जिसका निमोनिया हो रहा है उसको एक्स्ट्रा पल्मोनरी मैनिफेस्टेशंस नहीं आ रहे, और जिसको एक्स्ट्रा पल्मोनरी आ रहे हैं उसको पल्मोनरी इन्फेक्शन नहीं। सो ये हमें दो अलग अलग पाथवेज पे ले जा रहा है हमारे पास में। इसका आंसर आयुर्वेद में मिलता है। आयुर्वेद कहता है कि जब भी बॉडी में अग्नि खराब होगी तो सिर्फ 5 एरियाज में अग्नि आ सकती है। वो कहते हैं आलोचक पित्ता विच इज आई, भ्राजक पित्ता विच इज स्किन, देन साधक पित्ता विच इज हार्ट, पाचक पित्ता विच इज जीआई, रंजक पित्ता विच इज ब्लड एंड लिवर। और यहीं पर हो रहे हैं, यहाँ पर सारे मैनिफेस्टेशन यहीं पे आ रहे हैं। सो अगर मैं आयुर्वेद को लेकर चलूं तो पूरा डिफाइंड है कि ये मेरा वायरस कहाँ कहाँ जाएगा। सो मल्टी सिस्टम इन्फ्लेमेटरी डिसीज के अंदर में इन 5 के अंदर में ही इन्वॉल्वमेंट है। सो हम उनको ढूंढते हैं, 5 में निकल आता है, स्टेरॉइड देते हैं, ठीक हो जाता है। सो देयर आर सम, व्हाट आई वांट टू ट्राई टू से कि इसने, वायरस ने हमारे को लेटरल थिंकिंग पे मजबूर कर दिया।
या डेफिनेटली। अभी जो लेटेस्ट जो रिपोर्ट्स आ रही हैं तो उसमें दे से इट इज ए मास्ट सेल एक्टिवेशन सिंड्रोम, मकास, एंड देन जो डाइट्स हैं, जो हिस्टामिन रिच डाइट्स हैं, that should be avoided because already there is a mast cell activation, and ये mast cells तो आपको पता है पूरा GI में है, बाकी जगह पे है, तो there is a continuous release of histamine and causing, that is why you are having these autonomic dysfunction, instability, suddenly there is sweating, profuse sweating, temperature dysregulation, कभी पल्स बढ़ जाती है एकदम तेजी से, फिर BP fluctuations are there। तो डाइट में आई थिंक
हम एराकिनोटिक एसिड पाथवे को लेके चले, PLA2 वाला, जो एक तरफ ल्यूकोट्राइन्स की तरफ जा रहा है, एक तरफ PGE2 की तरफ जा रहा है। तो इसके अंदर में जो मॉन्टेलुकास्ट है, सो हम लोग तो सब में रूटीनली जहां पे उसको ऑटोनॉमिक डिसफंक्शन हुआ, हम साथ में मॉन्टेलुकास्ट दे रहे हैं, थिंकिंग इट टू बी ए ल्यूकोट्राइन इनहिबिटर, कि वो वाला जो पाथवे है वो भी इसमें इन्वॉल्व हो रहा है। तो हम लोग, वी आर गोइंग डीप इनटू पाथवेज and try to find out clinically कौन सा pathway इस patient में involved है। Is it a arachidonic acid pathway to PGE2 pathway? Is it leukotriene pathway? Is it nuclear factor kappa beta pathway? Is it TH1, TH2 और TH17 pathway? अगर आप patient को, I'm going more like a homeopathy now. होम्योपैथी वाले ऐसे करते हैं, एक एक सिम्टम पे जाके खोलते हैं पाथवे को, तो यहाँ पे कहीं ना कहीं पे फिट बैठता है और वो दवाई देते हो तो काम कर जाती है।
एक्चुअली अभी ये जो क्रॉनिक इन्फ्लेमेटरी स्टेट है, जो कहते हो आप स्मोल्डरिंग फायर की तरह, स्मोल्डरिंग इन्फ्लेमेशन, उसमें रिपिडिटी है, मतलब पेशेंट्स बिल्कुल दे आर लिथार्जिक, दे आर फटीग, टायर्डनेस, और मतलब मैं इवन स्लीप डिस्टर्बेंस बहुत हो रहा है, आप देख ही रहे हैं कि दे आर इन
इसमें हम लोग ये लेके चल रहे हैं क्रोनोलॉजिकल क्रोनोबायोलॉजी। हमारी जो बायोलॉजिकल रिदम है, ये वायरस अपसेट कर रहा है, बिकॉज वी आर गेटिंग लो ग्रेड फीवर which is coming in the afternoon and disappearing in the evening. So we are presuming it is also causing biodysregulation of the pineal gland melatonin. So therefore we are getting all the symptoms like a jet lag. तो इसके अंदर में अगर हम मेलाटोनिन 3 या 6 मिलीग्राम दे रोज का, so all these symptoms are becoming better. So what we are trying to do is we are treating them on the basis of a jet lag symptoms. So हम ये लेके चलते हैं, सेरोटोनिन इज इन्फ्लेमेटरी, मेलाटोनिन इज एंटी इन्फ्लेमेटरी। सो ऐसे केसेस में अगर आप इनको एंटी डिप्रेशन दोगे तो इनके सिम्टम्स बढ़ रहे हैं। इफ यू गिव देम SSRI तो इनके सिम्टम्स बढ़ रहे हैं। सो वी आर गिविंग देम मेलाटोनिन फॉर फ्यू मंथ्स एंड दे ऑल आर सेटलिंग। अब क्वेश्चन सिर्फ ये है कि मेलाटोनिन लिटरेचर में 600 मिलीग्राम तक लिखा हुआ है देने के लिए कि सेफ है, हाई डोज है, पीपल आर गिविंग हाई डोज, वी आर गिविंग लो डोज मेलाटोनिन एंड इट रिस्पॉन्ड्स।
I think we should not give more than 3 milligrams in majority of cases. because you require very little dose. It's basically it is released during dark period in the night when yeah. So even half tablet also may work in patients who are going to be responsive, because in many cases it causes a lot of headaches.
इंटरनेशनल ट्रायल इज मिनिमम 0.5 मिलीग्राम पर केजी बॉडी वेट, जिसको देते हुए हमें डर लगता है। उसके हिसाब से तो 40 मिलीग्राम देनी है जो लोगों के रिजल्ट। सो उन्होंने तो डेमोन्स्ट्रेट किया है कि 500 मिलीग्राम भी सेफ है इन एक्यूट फेज, बट वी आर गिवन maximum I have given is 12 milligram in patients for where there is a high CRP and biological rhythm disorders. Otherwise 3 milligram to 6 milligram. So this is harmless. Again, melatonin is harmless. It is a jet lag drug. आप सब लोग फ्लाइट पे लेते हो तो लेते हो। So हम लोग तो सिर्फ वो ढूंढ रहे हैं कि शायद काम कर जाए, हार्मलेस हो। एंड और जितनी भी चीजों को हम लोग स्टार्ट करते हैं, थोड़े दिनों के बाद में आप देखोगे कि वही पेपर निकल के आ जाएगा कहीं ना कहीं पे भी, वो भी लोग यही सोच रहे हैं हमारे बारे में।
वही है, as long as we are not when we are using off label usage of the drug, the dose should not go too high or too low, ताकि उसमें हमें अनयूजुअल साइड इफेक्ट्स ना हो, क्योंकि हमारा बेसिक प्रिंसिपल यही है इन दिनों में कि इफ वी कांट डू गुड वी शुड नॉट डू एनी हार्म। तो वो वही है मोस्ट इम्पोर्टेंट थिंग, एंड प्रैक्टिकली हमारे पास 2 ही ड्रग्स हैं, स्टीरॉयड और थोड़ा सा रेमडेसिविर, बाकी सब तो रीपर्पस ड्रग्स हैं, एंड वी आर ट्राइंग देम and some patients are getting benefit. So as long as there is no harm, I think we should try on some basis. As you have mentioned, you have talked about so many pathways, and whichever pathway in a particular situation you feel is working, I think there is no harm in trying these drugs. They are quite safe drugs.
So thank you Dr. Suri for here. It was wonderful talking. आपसे हमेशा मुझे कुछ सीखने को मिलता है, and I always admire you and always respect you a lot in your work. इसलिए मैंने कहा था कि सुप्रीम कोर्ट पे अपील लेकर आया हूँ कि मेरी ऑब्जर्वेशंस क्या हैं। So that's all for today. We will be back tomorrow 7 p.m. with another show. Keep watching Med Talks with Dr. Agarwal. We will be back tomorrow. Namaskar.
Thank you.